It's very fitting that next we have Dr. Shane McKee, who is the clinical lead for genetic medicine in the Belfast Trust. Shane is a man of many hats. He is very actively involved in a research study called DDD, which is a study that uses new technology to look at the genetic causes for some very rare and very unknown conditions. And Shane's also very involved in the Belfast Trust initiative, the Northern Ireland Electronic Care Register. And Michael mentioned that there are issues around information technology, and hopefully Shane will be able to tell you a little bit about how that is hoping to change. Thank you, Shane.
Thanks, Alison, and hello, everyone. I should, in case there's a concern that the Belfast Trust is driving the NIECR project, I'd have to say this is a regional project, and I just happen to be involved in the Belfast Trust element of that. But what I want to try and focus on is how this particular new technological development, which I'll explain to you, is joining together the information in pursuit of the major goal that we have of improving care. And it's that joining up and that information, I think it fits fairly well, I think, with the tagline for this meeting and for, in fact, the Rare Disease Day in general. But information is the key that allows different professionals and patients to communicate with each other and therefore to try and improve care. So what's the NIECR, the Northern Ireland Electronic Care Record? It's a relatively new project that's been running in the South Eastern Trust initially and has now gone live across the region. And it's a regional database of clinical information that relates to patients and pulls all their information from multiple different database sources together at the one time through one portal that's then accessible to doctors, nurses, healthcare therapists, and indeed patients in the clinic environment. There are many, many different databases in which your information and my information are all held. And one of the biggest frustrations that in genetics, because in the specialty I'm in, and I know several of you here, one of the most difficult things that we have is pulling together information from different sources and different specialists, even knowing who those specialists are. And if we're able to get that information very quickly, it means that the outpatient clinic experience becomes a much more useful and productive experience to have to go through. We recognise as healthcare professionals that demanding that patients give of their time to come up and speak to us and then maybe go away without very much being done is a huge burden, and it's not fair. So what we've been trying to do with this project is to try and improve that. So we've got this single access point for a lot of clinical information, and I'll go through that in a moment. But there are things, for example, like the discharge letters, clinic letters, so we can get rapid information that maybe hasn't been sent into to different sections of patient notes. This also works across sectors, so we're not just talking about the secondary or tertiary care sector, but also the primary care sector. So information that your GP has about you, about your medications, are also available at the time of clinic. I think a lot of people, once this is explained to them, they're starting to click and the pennies are starting to drop and they're sort of saying, well, I can see the benefits of a system like this. So this is a very hard view to see, but basically this is what you're seeing here, and you'll not be able to see this down the back, even at the front, is a dummy patient, but the number of information sources that are collated together and put up for this patient. So we have, for example, all the appointments that the patient has, outpatient appointments, inpatient care episodes, and GP information, medication information that's up here. We've got their up-to-date demographics. Anybody in the room has ever had a letter go to a previous address, or an appointment letter that's gone out to you and you haven't got it, and then you get a letter from the hospital at some stage telling you you've been discharged because you didn't turn up? Yeah. This kind of thing is because we have these old database systems that aren't talking to each other, and the hope is with this system that we can help to pull all that information together, and the regional aspect of it is something very important. So someone could, for example, go and see a paediatrician in Altnagelvin, and I'll have the outcome from that clinic at my clinic in Belfast if I'm seeing them at a clinic down there. So it means that it ties up that information. So these things become very busy, but actually after a while we find that we can get the hang of it. So how would a fancy computer system like this actually benefit people with rare disorders? And whenever the project came about, my first reaction was that this sounds great for people with rare disorders. In fact, if anything, better for rare disorders maybe than many other patient groups. It gives you an overview of the professionals involved. A lot of folks here, you'll realise that you see multiple different people. Sometimes you see them very, very briefly, and you maybe don't quite remember their name at the next time you're asked it at a clinic, or you assume that that person has written to your other doctor and told them about something, but they maybe haven't directly. So it helps to pull that together and gives an overview of who all's involved. So we're trying to join up the information and therefore improve care that way. It reduces the complexity of dealing with patient cases, and I think I'm going to sort of try and get sympathy for the health professionals here, that it's actually very difficult for us sometimes to pull together complex elements of care, but this makes it easier for us to do that, because I know I speak for the vast majority of health professionals in Northern Ireland and across the piece, that we're trying to make things better for our patients. We genuinely do care, and this helps us to try and deliver that care. The data flow between professionals, less need. If you come and see a new doctor, it's quicker if we've got all that information in front of us than sort of saying, so, tell us, what has been the problem with you this last 30 years? Where do I start? So we can get that sort of information then eventually from a system like this. Reduced need for lab tests and x-rays. We're hoping that maybe we won't need to get as many blood samples taken, won't need to get as many x-rays taken, as many MRIs done, because that information is going to be available to professionals there and then, and it informs the decisions that are being made to then do those further tests. This is a big, big benefit. And at the end of the day, it's brilliant for patients, but the Department of Health and the hospital trusts like it, because these things are all expensive items that come off their bottom line. So we're hoping that this is going to help divide the budget more equitably and allow a bigger bang per buck for patients, particularly with rare disorders and where there's multiple complex interventions required over the years. The other thing that I've mentioned there is that it helps the shared decision making. What I try to do in my clinics is pull up the electronic care record of the patient there in the clinic in front of them. Spin the monitor around. This is your record. These are your letters. You can see what this doctor has written about you. And then, if there's any inconsistencies with that, which there sometimes will be, that helps to get that ironed out. So far, our response from our professionals has been spectacularly positive. Some people have been calling this the best thing that they've ever had in healthcare. These are professionals, so the patients, I'm not sure whether they say precisely the same thing, but some very, very positive things coming from all grades of healthcare staff, doctors, nurses, podiatrists, physiotherapists, occupational therapists, because we have the information. So we're not trying to gather that again. We can actually deal with the patient who's in front of us, and that's vitally important. The sort of things, for example, about improvement to patient safety. This was a survey that we carried out in the Belfast Trust. There's either a good improvement to patient safety in the eyes of the professionals who are asked, or a dramatic improvement to patient safety because we're not mixing up their drugs and things. So these are big improvements that we're seeing. In terms of access to information, again, dramatic improvement in access to information speeds up the process of just getting that information to make your clinic appointment, and in fact make your general management more worthwhile. I've had patients who have turned up to my clinics, perhaps unexpectedly. There's maybe been a confusion with the appointment system, and usually they've been sent out a letter and then it hasn't got onto our system, and they've come up effectively blind. But I can do a clinic from the records that I have on this system rather than send them away to come back, so we can maximise the use of that intervention. The feedback that I've had from the patients so far on this system, the ones who have seen it, and if you are attending any clinics in Northern Ireland, I would advise you and recommend that you ask your doctor to pull up your electronic care record and let you see it. But it's been overwhelmingly positive. You can, as I say, you can see your records, you can see the scope of your attendances. It makes it a less random affair to be seeing all these things. And there's less need, as I said, to explain all this over and over again. I've had people ask, can I have access to my records on this system? Is there a patient portal, for example, for this? And this is something that has been built and is in development, but there are still a lot of decisions to be taken as to when and how we implement something like that, or even if. The professionals were all very, very keen on this. So patient access to information, we really want that. Can I add my own notes to this? Can I do a letter that sort of says, I have got X, Y, and Z, and I want my doctors to be aware of this? And those are things that we're looking at the moment, and I'm feeling fairly positive that this is going to be the way these things are going. So the sorts of challenges that we have, and those of you who would be familiar with the informatics development in the English setting will know that there's the care data database, and there's been a lot of discussion about the privacy of information and will that information be sold off. This is a very secure database. It's been specified specifically to access information for patients on an individual patient basis. So it's a secure and safe database, and a lot of the mistakes I think that were made in other healthcare systems across the world in data access, we've learnt from those and built a very, very solid system, and actually, funny enough, made it very affordable for our taxpayers. So this is going to be a very cost-effective intervention. It allows us to integrate new data systems and bring them all together. It allows us to map out improvements in patients' care, and also keep I can't even remember what that CE actually stood for now, but we're keeping people informed, and we're trying to improve care across the region in Northern Ireland, and hopefully then to make that an improvement right across the piece in the UK and Ireland, particularly with our north-south dimension. So this is the sort of screen that we get. We log into this and it's all go. So it's a very positive thing. Before I finish, I just wanted to very quickly mention that in rare disorders, we are very focused on research, and we feel, those of us who are working in rare disorders, we feel that research at a very fundamental level is key to delivering actual health care. And in many aspects of healthcare, you maybe sort of see a bit of research that's being done, and you're told that there may be some treatment 5 or 10 years down the line. So 5 or 10 years later, you come back and you sort of say, well, where's this treatment? And it's not there. In genetics, we like to think that we get some aspects of that through very, very quickly. So some things that we're doing, for example, this DDD project, which Alison mentioned, stands for Deciphering Developmental Disorders, and we're using the latest genetic sequencing technology in collaboration with our colleagues in Cambridge to sequence all the genes in children with developmental disorders. We're trying to recruit 12,000 children to that, and so far we have 450 children from Northern Ireland recruited into that study. It's also running in the south as well, so we're very, very happy about the way that's going. We've also been able to get what's called a Musketeers Memorandum together. So for non-interventional studies to try and understand how genetic disorders work, we've been able to get agreement from the research governance people who keep an eye on research that if these are rare disorders and they're scattered across the UK, we can pull them together, and approval in one region will automatically signal approval in another region to speed up research and get benefits back for families. So that's what we're trying to do, and I think we are heading that way, but obviously it's going to be a long road, and we're going to keep trying. Thank you.